PGY1, internal medicine resident at Oregon Health and Sciences University, Hillsborough Medical Center. Today I'm going to present a clinical vignette as a poster, the title of which is An Elusive Diagnosis, Disseminated Tuberculosis. The treatment team and presenters of this case include myself, Dr. Mark Skura, PGY1, Dr. Christopher Lopez, attending physician, internal medicine, Dr. Cameron Black, PGY1, Dr. Kristen Morton, PGY1, Dr. Zhen Zhu, PGY1, and Dr. Cherie Gaz, attending physician, pulmonary and critical care medicine. Introduction. In the Americas, tuberculosis makes up 2.9% of global incidences. Disseminated TB, or DTB, results when Mycobacterium tuberculosis spreads hematogenously to other organs, resulting in a nonspecific clinical presentation which poses a challenge for timely diagnosis. Common symptoms include fever, fatigue, anorexia, weight loss, cough, and, less commonly, hemoptysis. Common organ involvement includes musculoskeletal at 41%, pleura at 26%, the meninges at 6.8%, and disseminated and lymphatic and others in lesser percents. Here we present a case of an individual who had 3 admissions with nonspecific symptoms within 2 months without a clearly unifying diagnosis. The first presentation was for generalized weakness, dysphagia, and B-type symptoms with pulmonary and GI lymphadenopathy findings on CT and an otherwise normal upper endoscopy. The second was for septic shock thought to be due to diverticulitis in the setting of presumed malignancy, for which he underwent bronchoalveolar lavage with negative AFB smear, though mycobacterial cultures were still pending at time of discharge. The third hospitalization was for sepsis of unknown source, with incidental findings of periaortic lymph node enlargement and polyarticular gout flare, for which he was treated with corticosteroids with improvement in his symptoms and discharged on a steroid taper. Of note, he did not make it to his oncology appointment planned after his first admission, where PET scan would have been considered. Case report. An 81-year-old male who emigrated from Korea 30 years ago with a history of diverticulosis, gout, psoriasis on adalimumab, and dysphagia presented with weakness and shock. Initial vitals revealed a temperature of 37.2 Celsius and a blood pressure of 65/40 without hypoxia and a 7-kilogram weight loss since first admission 2 months prior. In the setting of a steroid taper for a gout flare above, he was treated empirically for relative adrenal insufficiency in the setting of shock and vasopressors in the ICU. Unfortunately, his thoracic and abdominal lymphadenopathy did not have a good target for radiologist-guided biopsy to assist in diagnosis. An EGD was repeated in the setting of dysphagia and weight loss, though this was again unremarkable. Without obvious infectious etiologies during his current and prior admissions that would explain recurrent episodes of shock, adrenal insufficiency was considered in addition to malnutrition in the setting of possible malignancy. It was during his third admission when we were contacted by the Oregon Health Authority with results of his prior mycobacterial cultures that had resulted positive 8/10/2021 from initial testing in 6/26/2021. He was immediately placed on appropriate precautions and treated with RIPE, that is, rifampin, isoniazid, pyrazinamide, ethambutol therapy, for 2 weeks as an inpatient, followed by full treatment of 9 months outpatient per CDC protocol. His clinical improvement and ongoing stability since initiation of RIPE therapy suggests that his recurrent presentations for shock were in fact due to disseminated tuberculosis involving his adrenal glands. Above, we have pictured CTs of the patient's chest, with figure 1 displaying an upper lobe pulmonary nodule measuring about 12 millimeters, seen during the patient's second admission. Below, in figure 2, shows multiple upper lobe predominant pulmonary lung nodules in the perihilar as well as peripheral lung fields. Discussion. The diagnosis of disseminated tuberculosis without pulmonary symptoms remains challenging because rapid tests lack sensitivity, sensitive tests are slow to result, and rapid tests with high sensitivity studies may be high risk or unobtainable, as was the case for our patient. Prior to starting adalimumab for his dermatologist in 2019, it was noted that the patient had a negative interferon gamma release assay, IGRA. Although the overall sensitivity of this test is 80.2%, the sensitivity tends to decrease down to 68.2% for adults older than 70 years old. Additionally, there was only one sputum sample collected for MTB smear microscopy, which resulted negative. It is not uncommon for negative smear microscopies to result with positive cultures. In one retrospective data analysis of pulmonary TB, where 3 samples were obtained, found that 58.9% of culture-positive TB resulted in negative smears. Our time to diagnosis was further limited by the incubation period of the sputum culture. About 99% of sputum MTB cultures result in 28 days, but it took about 6 weeks before our cultures grew MTB. The quickest possible route to reach a timely diagnosis would have been lymph node biopsy. In hindsight, our patient's demographics, comorbidities, and clinical findings were indicative of disseminated tuberculosis. We anchored on malignancy with a single prior AFB smear and negative IGRA. This case serves as a reminder that it is important to maintain a broad differential when the diagnosis is not yet obtained, and to avoid dismissing a diagnosis based on lab testing alone when the clinical picture may still fit that diagnosis. I thank you very much for the opportunity to participate in the ACP poster presentation competition of 2021.